Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, Honorable Dean and Academic Leaders, Faculty of Farmasi, Universitas Pancasila, Ibu Notori, thank you for facilitating this session, Ibu. Distinguished speaker, Dr. Lum Zheng Kang from Singapore, thank you for your time and availability and of course your effort to fly to Jakarta. Welcome to our wonderful Indonesia. Honorable lectors, beloved students, both those who join online and join in this room, thank you for participating. Last but not least, to all participants and committee, welcome to this hybrid visiting lecture with theme Revolutionizing Diabetes Care through Person-Centered Interprofessional Care Models. We honored to have you here today. My name is Farah Diba, you can call me Diba. I will be hosting this visiting lecture for the next 2 hours. Our schedule will continue with Indonesian National Anthem and Mars Universitas Pancasila, and then remarks from the Dean or for the Vice Dean, Ibu Gresti Vinotori, and continue with the lecture from Dr. Lum Zheng Kang and end with Q&A session. I will not be alone. Prof. Hesti Utami will accompany me as a moderator. Before we begin, I would like to invite everyone to stand for the singing Indonesian National Anthem and Mars Universitas Pancasila. Thank you. Please be seated. Next, remarks from Vice Dean of Faculty of Pharmacy, Ibu Dr. Kristivinotori, Master of Pharmacy. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Sorry for our Dean, Professor Samsudin, because unable to give a speech due to a sudden agenda in Rector. Good morning everyone. Assalamualaikum warahmatullahi wabarakatuh. Salam Pancasila. The Honorable Dr. Lum Zheng Kang is the CEO and founder of Collaborating as speakers. The Honorable lecturers, students, and participants. I would like to welcome you to our campus, Faculty of Farmasi, Pancasila University, a campus that applies to noble value of Pancasila. I am very grateful for your presence on your campus to share your knowledge about community-based medical clinic to provide interprofessional health care. This partnership combines its pharmacy expertise with the goal of improving medication management and improving clinical outcome and quality of life for the community. With a strong interest in patient-centered interprofessional care. Maybe I will say with bahasa. Untuk mahasiswi dan mahasiswa Fakultas Farmasi, galilah ilmu sedalam-dalamnya pada pertemuan pada pagi hari ini dengan didampingi oleh Prof. Hesti selaku moderator yang sudah tentu pakar di bidangnya, lalu dengan narasumber dari pihak internasional. Misi dan visi dari FFUP untuk menuju go internasional sudah terlihat ya. Jadi nanti mungkin ada pertanyaan atau apapun untuk pengembangan diri dapat adik-adik atau mas sama mbak sampaikan kepada narasumber yang sudah sangat spesial hadir di momen ini. Finally, I would like to convey my congratulations again to the audience for holding this guest lecture. Hopefully many ideas can inspire the audience through today's guest lecture and become blessing of knowledge for us to put into practice together. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Now I'd like to invite Prof. Hesti Utami to the stage. Please, Prof. Hesti. I will read her CV first. Prof. Hesti Utami Ramadhaniati, Master of Clinical Pharmacy, PhD, born and raised in Palembang, West Sumatra. She is pharmacist by training in Universitas Gajah Mada. Gained her Master of Clinical Pharmacy program in the University of Queensland, Australia, and doctoral program in the Curtin University with scholarship from Australian government. She joined many professional associations and had numerous academic achievements, including international journals and research grants from such as WHO, NIHR, UK, and many more. Without any further ado, Prof. Hesti Utami, are you ready?
Yes, I think.
Yes, over to you.
Okay. Thank you, Ms. Paradiba, for the nice introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning. How are you today? Good? Good. Okay, it's Monday. Hopefully we have much energy from the weekend because today we have our guest coming from Singapore to give the guest lecture. Okay, I will be moderating this guest lecture. We are so honored to have Dr. Lum Zheng Kang. Is it right to pronounce? Lum Zheng Kang. He is the CEO and founder of Collaborating, where he drives advancement in health service research and clinical practice. He is holding a PhD in health service research and bachelor degree in pharmacy from National University of Singapore and US. With a strong interest in interprofessional person-centered care, Dr. Lam has published his research in many international journals and regularly present at global conference. Dr. Lam's commitment to integrating research and clinical practice underscore his dedication to transforming healthcare and enhancing patient care. Okay, I will not read through his extensive and outstanding CV. We don't have much time for that. Without further ado, I would like to invite Dr. Lum Zheng Kang to come forward to give his lecture on revolutionizing diabetes care through person-centered interprofessional care models. Do you think you can finish within 45 minutes? Sure, because then we will have much time for discussion. Okay, the time is yours.
Morning, everyone. I'm so happy to see everyone here on a Monday morning, and thank you, the organizer and Prof. Samsudin, for inviting me here. Really beautiful city, and when I came in, it's really a very beautiful campus. And it's really also very heartening to see that, in your campus, you have the worship places for all the religions here. So really very happy to be here today to share with all of you, in Singapore, what we have done with regards to the diabetes care and what kind of care models that we have and how we are engaging our community pharmacy. So I have no conflict of interest to declare, and anything that I present today are all my personal opinion. So I will start off with introducing all of you the Singapore healthcare landscape, our national strategy. I will also talk a little bit about the principles of person-centered care before going into the roles of community pharmacists and also a few case studies about what we have done with regards to the community pharmacist care models and what can we together move forward in advancing our pharmacy profession. So Singapore is a very small country. I believe all of you know it's somewhere that you can't really see in the map, and we have around 6 million people. So in Singapore, 80% of our primary care is actually delivered through the private healthcare sector, namely the general practitioners. And we also have the public healthcare in the primary care. We call it the polyclinics, where they serve around 20% of our population. So in terms of acute care, predominantly is delivered by our acute hospitals, and they are the private institutions. So in terms of our private healthcare system, our government has segmented our whole island into 3 geographical areas. The western region, which is taken care by the National University Health System, the central region by the National Healthcare Group, and the eastern region by SingHealth. So within these healthcare clusters, we have the acute care, the tertiary hospitals. We also have the step-down care community hospitals, as well as the primary care, which is the polyclinics. And all over the islands, we are also served by our private healthcare partners. While we know that they are generally the general practitioner clinics and the acute hospitals, we do have quite a number of community pharmacies within our primary care setting that is involved in many of the chronic disease management, preventive health, and as we are facing also the aging population, community pharmacists in Singapore play a more vital role in education and empowerment. So last year, our Singapore government launched the Healthier SG initiative. This is the national strategy framework, which actually anchors on preventive care and encouraging healthier living, and also hopefully to empower our residents to take up responsibilities to adopt a healthy lifestyle. And this is also why our community healthcare partners, including community pharmacists, they have a vital role to play in the future landscape of the Singapore preventive healthcare system. And again, because we are talking about getting all our healthcare partners together, we cannot run away from interprofessional collaborative care. And through this national strategy, we are not only encouraging doctors to take on the responsibilities in providing most of the care, we are also now engaging our other healthcare professionals like the physiotherapists, psychologists, pharmacists, nurses, dietitians, and many other professionals. So it is really about how we can deliver person-centered care, where our healthcare system focuses and anchors on shared decision-making with our patients. And this is also facilitated by the increased health literacy and the overall literacy level of our population. So in Singapore, we are seeing more and more of our residents that are able to source for information by themselves. But the problem here is that sometimes they still lack the ability to evaluate or to assess the information. And again, this further strengthens our so-called call to engage the community pharmacists. So later on, I will share a few case studies as to how we are engaging our community pharmacists, as well as some of the research that we have done in Singapore. So just to run through some principles of person-centered care, while we are talking about having the patient in the center of the care model, anchoring on shared decision-making, respecting values, preferences, and beliefs, but person-centered care is beyond just the patient, but also the entire ecosystem, where we ensure that the healthcare professionals in the care team is actually so-called, for a lack of better word, relevant in managing, in this context, diabetes. For example, we have the dietitian, we have the endocrinologist, we also have the nurses for the various aspects of diabetes care. So, so I'll move on quickly in view of time to just show you that, diabetes care is really complex and multifaceted. We are not only talking about endocrinologists, general practitioners, pharmacists today, but we are talking about the entire web of care involving dietitian, nurses, even family members and caregivers. And on the slide, you can see that this is a rather common scenario that we see in Singapore. We have residents who suffer from the complications of diabetes, who goes in and out of hospitals. And if you were to look closely, this was a report quite a number of years ago. So within the last few years, we are really dedicated and motivated to ensure that our residents are well taken care of. We want to provide a safety net in the community because many of our residents with diabetes are actually community dwelling. And this again further supports our case and our drive for the Healthier SG initiative. So just some statistics. The global diabetes burden has been rising and is definitely going to rise even further by 2040. And not only just the prevalence is accompanied with significant economic burden. Again, not only the direct medical costs, but we see that significant indirect costs attributed to labor force dropout is contributing to the economic burden. And again, today I'm promoting the value of interprofessional care. But before that, let me just share a little bit about the challenges of the slightly traditional physician-centric models in Singapore, where the physician alone has to take on responsibility from disease assessment to education, lifestyle counseling, even all the way to ensuring that the patient receives the adequate financial support. So again, in Singapore, we promote the co-responsibility or co-payment. So sometimes the healthcare bills can be very expensive. So the physician has to take on the responsibility in talking and discussing with the patient how they can actually reduce the healthcare costs. And what the physician face are actually time constraint. We have aging population. And by next year, we are considered a super aged society, which means that around 20% of our population are actually above the age of 65. So we see that in clinics, the physicians are really pressed for time. They have to choose amongst the assessment, medication management, lifestyle counseling, other social and economic aspects. They can't really address every single aspect. So that again, is complicated with so-called the complexity of diabetes care. Every resident, every individuals, they are different. They have their own belief, perception, unique cultural and religious needs. Not only that, the disease state itself also brings upon many factors, such as the medications, optimization, social support, quality of life. And all in all, it is just really complex for just a single professional. And here, before I even go into the roles of pharmacists, I also want to make it a point that pharmacists also can no longer work in silo. We do need to collaborate with the physician, with the nurses. And therefore, we are seeing a paradigm shift in the healthcare delivery models from the physician-centric model to one that is interprofessional, collaborative in nature. And we engage the patients as a core decision maker in developing their care plan, and it is all guided and targeted towards realizing their health and life goals. So we really need to engage all the stakeholders within the healthcare ecosystem, not just the patient and the healthcare providers alone. So there are many healthcare professionals, as I shared, in the web of care. Today, I will zoom into the roles of community pharmacists. And this is also our strategy in Singapore, where we are encouraging our community pharmacists to take up more active roles in promoting healthy living, as well as supporting chronic disease management, being an expertise, an accessible expertise for medication-related inquiries. So just to share a little bit with regards to the community pharmacy setting. So in Singapore, it's a very dense country. We have malls, we have buildings within a few meters. And within these buildings, we can easily find at least 1 to even 3 community pharmacists. So all in all, our community pharmacists in Singapore is readily accessible. You just have to walk like even just 1-2 minutes. So that is the reason also why we believe that community pharmacists should go beyond just the sales of medications, but towards the promotion of healthy living and medication management, supporting physician as well with regards to medication-related matters. So I would like to summarize here with the 3 key roles that community pharmacists can play in Singapore. And I've talked extensively about medication management, but not only that, it is also the education, lifestyle counseling, and serving as a knowledge and information hub. So as I've shared briefly just now, in Singapore, our community pharmacies are located within the malls, within buildings. They are in a more relaxing setting. And this relaxing setting, actually, we have some findings to show that the patients are more open to sharing. They are not so tense when they go to the hospitals, when they go to the clinics, they get very worried about their condition. So that actually serves as a good starting point for our community pharmacists to really empower our residents in Singapore. And not only that, these community pharmacists, as I said, we have 2 to 3 so-called shops in just a single building. That gives them a lot of time to really address the various aspects of care, to really understand the individuals. So that is why, again, all in all, I believe that community pharmacists can really play a very important role, especially in education and empowerment. So because of this belief, I think around 2018 and 2019, we started a diabetes care program in the community where we engage the private community chain, and that is abbreviated as the D-Care program. So this diabetes care program only engages community pharmacists to provide pharmaceutical care services, from goal setting, review of medications, counseling, empowering them for the self-monitoring of blood glucose, and also recommend titration of medications. But if you hear me, correctly, I said that this only involves community pharmacists. So therefore, some of these activities really rely on the patients to translate from their doctors, from their other healthcare providers. So just this program alone, we saw significant improvement in clinical outcomes, including the HbA1c, blood pressure, and cholesterol over around, I believe this findings was around 12 months when the patients engaged in this program. So we actually got individuals with type 2 diabetes, and if they have hypertension or hyperlipidemia, they are eligible for this program. A number of sessions over 1 year where they will see the community pharmacist face-to-face and as and when required with a telephonic follow-up. And this was conducted in a retail pharmacies back then in Singapore. So we do provide our residents with the glucose meters. This is to incentivize and motivate the individuals to really monitor their blood glucose, and that in turn will definitely help the community pharmacists to be more targeted in adjusting medications, recommending the optimization of medications. So the objectives is really to enhance the roles of community pharmacists in diabetes care, but at the same time, it is also to bring about clinical and humanistic outcomes improvement and eventually to promote healthy living. So we really want the healthy residents to come up to our community pharmacists and say, you have this program, but I don't really have diabetes, but I want to learn more, how can I prevent? So that is our longer term strategy and objective. So we see our community pharmacists within this D-Care program to really identify gaps, reinforce knowledge, promote self-management, doing some medication reconciliation, medication management. And we also believe in the enablement from technology. So we actually collaborated with a private company to set up an electronic medical records for this D-Care program called the Health Assist, where our community pharmacists can record the interventions, can record the conversations with the patients. But having said so much, if you recall back the last few slides, it is all about community pharmacists playing a role within this D-Care program. So this actually has some limitations, and this is an example where we are seeing pharmacists working in silo. First, these pharmacists are heavily dependent on the patient to communicate their medical records because our private community pharmacists will have no access to the patient's records. So it is all dependent on the patient for their medications, for their medical history. So all the care plan is then developed dependent on that. And obviously, many of our residents with comorbids visiting multiple hospitals and institutions will not be able to give an absolutely accurate picture. And second thing is that while we have the technology to enable documentation, what is actually lacking? The gap is actually the direct communication between pharmacists and the patient's primary care providers. So what we did in this program was to write a memo or a referral letter, and again, we depend on the patient to bring this back to their doctors. So there could be some sort of gap in the communication. So because of this, we feel that having community pharmacists in the residences or residential area is indeed convenient, but it may compromise on the care quality just because of the information that is limited, right? So because of that, we thought that we wanted to bring community pharmacists into the primary care setting. So as I've shared just now, 80% of our primary care is provided by private general practitioner. So after our first launch of the D-Care program, we actually engaged the community pharmacists to be situated within our general practitioner clinics. So this really forms what we call the interprofessional care model. And within these general practitioner clinics, we do have nurses as well. So we see that, the pharmacist, the physician really come together in the same consult room to discuss the medication plan, to discuss the assessment, and this really facilitates the communication, and all the stakeholders within the healthcare team really understand one another. So we saw that, there's really a benefit for engaging community pharmacists, and back then we already found literature from Europe and US supporting the value of community pharmacists involved collaborative care. But in Singapore back then, it was not evaluated extensively through randomized control trial. So now I'm shifting gear a little bit to talk about the research aspect. So when we launched this interprofessional care model, we also coincide with a designed multi-center randomized control trial. And this was mainly conducted within the general practitioner clinics. We have 3 clinics that we engaged in, and the ethics was approved by the University Ethics Board. So we have 3 main objectives, not only to evaluate the clinical outcomes over 6 months, but also to look into the improvement in other humanistic aspects such as self-care and quality of life. And again, because the healthcare cost in Singapore is not as affordable to all, we also want to evaluate the economic outcomes, mainly the direct medical cost and the indirect cost. So we had drawn up the inclusion criteria to be very similar to the DCARE program, but one additional aspect that we included is actually patients with polypharmacy, because based on the DCARE program, we find more value in pharmacists addressing polypharmacy issues. And because this care model was developed together with the general practitioners, we can facilitate communication easily, and our general practitioners can then prescribe the medications. So randomized control trial, we randomized based on the different HbA1c strata from the better controlled 7 to 8%, and we have another strata 8 to 10%, and those above 10% who are poorly controlled. So in terms of the training for our community pharmacists, we require the community pharmacists to participate in a 3-day diabetes certificate program back then organized by the National University of Singapore. And on top of that, we will require the community pharmacists to also attach to our public healthcare institutions, specifically the tertiary hospital, to undergo an experiential training at the diabetes clinic for around 2 weeks. And today, this training program has evolved not only in terms of diabetes care, but to cardiometabolic diseases as well as renal diseases. So the university had a second run of the program last year, July, and I believe the National University of Singapore will also conduct a training in this year, July as well. So in this program is the 2 to 3 day workshop where we share multiple aspects of cardiovascular, cardiometabolic, and diabetes care not only from the physician perspective, but we also engage podiatrists for the food screening. We also engage ophthalmologists for the eye. We also engage nurses to talk about nursing care in diabetes. So back to this randomized control trial, in terms of the intervention conducted by the community pharmacists, total there are around 5 to 6 contact points. The first 2 are actually in-person session in the general practitioner clinic. So the first session, right, is really to take the history, understand the background, develop the medication action plan, provide some education in terms of the self-monitoring of blood glucose techniques. And then after 4 to 6 weeks, the patients will come back again where the session will focus more on education, empowerment, goal setting as well. And then we have the community pharmacists follow up through telephonic calls for every around 4 to 6 weeks to just ensure that our patients are well taken care of. So as and when the community pharmacists identify any issues or matters that has to be addressed by the general practitioners, they will then ask the patient to return to the clinic. So this telephonic calls is also really to add on the convenience for our patient. And bear in mind that all these patients, they are all community dwelling. And in fact, many of them are quite stable in terms of their diabetes control. So therefore, again, this also serves as a safety net. While they are stable, we want to continue monitoring them, ensuring that if they have any questions, or if they don't really understand their medications, they have someone that they can talk to. So in terms of outcomes from the direct clinical outcomes such as HbA1c, blood pressure, lipids, we also measure quality of life and self-care. And in terms of the economic outcomes, we measure the direct medical cost, we measure the work productivity as well. So just to share a little bit about some of these patient-reported outcome measures that we used. For quality of life, we used the this audit of diabetes-dependent quality of life, ADD-QOL, which measures both the impact of specific activities as well as the importance of that activity to the patient. So in the next slide, I will show you an example where some of these domains of the questionnaire. So this ADD-QOL, I believe, was recently validated in Indonesia as well. These are some of the example questions. So we will ask the patient, for example, how diabetes has affected their walking and various aspects of life, and how do they rate the importance of this. And we have these questionnaire have around 19 domains, and then eventually we'll pull together a weighted score to represent the overall effect on their quality of life. And in terms of self-care, we use the summary of diabetes self-care activities, again measuring the various aspects of the lifestyle from diet to exercise, as well as the blood glucose taking and food care. So this measure actually measures their self-care activities over the past 7 days or 1 week. And again, this is an example of the questions. And I believe this SDSCA also has been validated in Indonesia recently as well. So in terms of work productivity, we use this work productivity activity impairment general health questionnaire. So this questionnaire actually measures various domains from absenteeism, which is so-called the individual being absent from work due to sickness, presenteeism, which means the individual not functioning at the optimal during work. It also measures the effect on work productivity and also the overall general activity impairment. So from this questionnaire, we then computed the numerical indirect costs through estimating from the gross monthly income as well as the hours of work in Singapore. So statistical analysis-wise, we had the sample size calculated based on our earlier study conducted within the tertiary hospital. So I will not dwell too much into these details in view of time, but quickly to share with you some of our key results. So we actually enrolled around 265 patients, and eventually 175 of them completed the 6-month program. And these demographics are quite representative of our Singapore population as well. And we actually collected quite a number of information, not only from demographics, but also the medications and medical related details. And we saw that there was a significant improvement in HbA1c, not only at 6 months, but in fact, at 3 months, we do see significant improvement already in the intervention group. So we thought that this could be attributed to the extensive education and discussion with the patient within the first 2 visits. Because if you look at the timeline, the first 2 in-person visits were conducted within the first 3 months. So blood pressure and lipids, we did not see significant improvement, but we actually saw a maintenance within the intervention group, as well as actually lipids as well. So these cardiovascular markers a longer term to observe any significant improvement. And in terms of hypoglycemic events, most of the patients did not suffer from significant or severe hypoglycemia. But one notable finding is that actually for those patients who have participated in our community pharmacist program, actually there is a significant reduction in the proportion of patients having severe hypoglycemia within the 6 months. And quality of life, we are heartened to see a promising outcomes where, again, there's a significant improvement. Likewise, for the self-care capabilities. I think we saw the improvement in self-care capabilities across general diet, SMBG, and food care. And we believe that these are also the aspects that was intentionally curated and developed into our community pharmacist interventions, not only within the first 2 visits, but through the telephonic follow-ups. We do actually ensure that our residents are empowered with these necessary self-care knowledge. So those were actually analyzed with the 265 patients. And when we adopted the per protocol analysis, the findings were actually similar. Significant improvement in HbA1c, significant improvement in quality of life, and self-care capabilities. So direct medical cost-wise, a lot of numbers here, but if you just focus on the total cost, we actually see a slightly significantly more or rather greater reduction in the total costs. And we also noted that medication cost was actually the main cost driver. And again, we saw a greater reduction in medication cost as well. However, for the indirect cost, we didn't really observe any significant improvement. But again, our team believed that this could be attributed to a few factors. These indirect costs were so-called calculated based on the patient-reported hours of work and the patient-reported so-called their details in terms of their gross income. So all in all, this RCT has given us some confidence in encouraging community pharmacists involved in interprofessional care in Singapore, and especially in terms of improving the clinical outcomes as well as the overall quality of life. So because of this, right, we now is moving towards really engaging our community pharmacists in diabetes care, and we are also continuously generating research outputs to further strengthen the value of our community pharmacists. And this is actually to our general population. So what else have we done? So we have also looked into our Muslim friends within Singapore, where we are not just focusing on the overall diabetes care, but developing guidelines and care models to address diabetes or to manage diabetes during Ramadan. So we started out first by developing a clinical algorithm in terms of guiding our general practitioners on how to titrate medications, how to educate our patient with regards to Ramadan nutrition plan and certain Ramadan specific advice. And this was developed by ambulatory care pharmacists, and we convened an interprofessional care team comprising endocrinologists, nurses, dietitians to actually refine this algorithm. And our main reason for creating and developing this algorithm is that in Singapore, many of our general practitioners, they are not very much aware and they are not very much knowledgeable with regards to Ramadan specific medical advice. So we hope that this can be a kickstarter for our general practitioners to be able to participate actively in managing diabetes during Ramadan. And again, this was actually done in around 2017, where we also pilot tested the algorithm amongst people generally with well-controlled or better controlled diabetes, who fast at least 10 out of 30 days during Ramadan. And outcome measures wise, we measure HbA1c, fasting glucose, in terms of safety, the hypoglycemic events as well. So this is an example of the algorithm. So we started with the patient screening to find suitable patients that align to our criteria, and then we provide the Ramadan nutrition plan. We provided the education. We also engaged the masjid in Singapore to actually promote some of this Ramadan specific education as well to our Muslim friends. And the next section on the dose modification is really to guide the healthcare providers to account for the fasting and also the fasting duration. Not only that, we also want to empower our patients to take charge of their health. So the second part of the algorithm actually focuses on how patients can actually adjust their medications within a certain limit based on their self-monitoring of blood glucose. So we recommended the 4-point glucose testing during Ramadan. I understand that according to the DAR International Alliance guidelines, they actually recommend a 7-point testing during Ramadan, but we thought that it may be too burdensome for our friends in Singapore. So at least we recommended one fasting blood glucose testing as sahur, and then one at iftar, and then another one is the postprandial at night after the Tarawih prayers. So we also have this patient information sheet where we give our patients to advise them on their medication regimen, how to take it during Ramadan, how to adjust it based on certain medications. As you know, not all diabetes medications require adjustments, and then how they can revert back to their original medication regimen. So after developing the algorithm, we thought that it will only be useful if we can so-called enhance its impact. So we actually designed a randomized controlled trial and we partner with an acute hospital as well as a primary care polyclinic in Singapore to evaluate the impact of the algorithm. Not only the clinical aspect, but also the safety aspect. So all in all, we saw significant improvement in HbA1c, especially from the time point of pre-Ramadan, which the pre-Ramadan visit is actually 4 to 6 weeks before Ramadan, and then to the post-Ramadan, which is again 4 to 6 weeks after Ramadan or even during Raya. So in terms of safety-wise, we did not see significant differences between the intervention and control group, but we are also heartened to see that there isn't a significantly large proportion of patients with hypoglycemia. So with this, right, we are gaining more confidence that, it is not just an algorithm, but we want to develop a Ramadan clinic. So on this note, I think I just want to share that I together with a few colleagues, participate actively in the DAR International Alliance, where we provide training for our healthcare providers in managing diabetes during Ramadan in Singapore. So we have this train the trainer workshop where we engage our healthcare providers usually 3 months before Ramadan, and we encourage them to actually, create their Ramadan clinic visits 4 to 6 weeks before Ramadan. So personally, myself, I've worked together with a geriatrician clinic, a Lami clinic in Singapore, to set up this clinic Ramadan. And we actually, this was our first year. And this clinic, what is again special is that it's not only general practitioner driven. We have pharmacists on board. In the clinic, we have nurses. So as you know, during Ramadan, not only we need to address the dietary aspect, development of the Ramadan nutrition plan, we need to address the exercise aspect, address the risk of dehydration, hypoglycemia. We also need to adjust certain medications, for example, sulfonylureas, which we don't really use in Singapore anymore, but not only that, things like, or rather medications like SGLT2 inhibitors. And then we also have to continue monitoring the glycemic control. So that, really enhances our value, because our clinic is not only engaging the doctors, but an interprofessional team. So just to share a little bit about the clinic, we have the first visit 4 to 6 weeks before Ramadan, where we do the risk stratification. We were advised based on the DAR International Alliance guidelines, and we will provide the dietary advice, exercise, lifestyle counseling, adjust the medication. So for certain patients in Singapore who are keen to fast but may possess higher risk, we will advise them to trial fast, which is on the 14th to 16th day of the month before Ramadan, and that would be quite ideal. And we also encourage our Muslim friends to fast, usually during Thursdays. And during the Ramadan, we will follow up with phone call to assess their conditions and how, and also their knowledge with regards to the adjustment. And if required, we will also call them back to the clinic. And then the post-Ramadan conducted, we aim to conduct 2 to 4 weeks after Ramadan to revert them back to the original medication regimen. So this is my team. So actually to my left, she's a psychologist. We have a clinic assistant, geriatrician in the middle. We have nurses, and we have general practitioners. So this interprofessional care team is not only for Clinic Ramadan, but this is how we are running the geriatric and general practitioner clinic in the community all year long. So we believe a lot in engaging the different healthcare professionals coming together in the same setting for discussion. So on this note, again, as I said, yearly we have the DAR conference. So this year we will be organizing the DAR Global Conference for Diabetes Management during Ramadan in November in Kuala Lumpur. So I welcome all of you to my hometown in Malaysia. So with all this said, we have the community pharmacist program. We evaluated through randomized control trial within the one primary care clinic and one tertiary hospital. The question is, what is next? I think that the issue here is that researchers do a lot of research, but it's always in a very structured, robust protocol, and also in a very limited setting. While we are very excited and happy with the promising outcomes, but the question here is, how do we actually scale and sustain such clinical services? How do we implement it across the nation, for example, or even the region? So therefore, right, it is very important that we really look into bridging the research to practice gap. We have structured research protocols, but are we engaging the stakeholders from the hospitals? Are we engaging the administrators? Are we looking into implementation measures such as patient acceptance, uptake? You can have wonderful clinic Ramadan, but if no patients come to your clinic, right, how wonderful can it get? So today, in view of time, I will not go into the whole realm of implementation research, but I want to leave you thinking, how can we implement some of these clinical services and eventually scale and sustain it? So back to the web of care. I hope that I have given you some preview into how important interprofessional collaboration is. And if we talk about diabetes care, I think many of you would relate to, having endocrinologists, having psychologists for the mental health aspect, having nurses, having dietitians for the dietary aspect, even physiotherapists and this exercise physiologists for the exercise aspect. But I think there is one profession that perhaps we have overlooked. And that profession is perhaps the dentist. I think when we talk about diabetes care, we always talk about cardiovascular complications, we talk about renal complications, we even talk about cognitive functions. but we never really talk about oral health. In fact, there are a lot of research that has been done to show the bidirectional association between gum diseases and diabetes. So gum diseases such as periodontitis that you are seeing on the screen here. So these periodontitis are actually so-called irreversible. So unlike, just simply inflammation. And there are a lot of literature associating the increased incidence of diabetes amongst people with periodontal disease. And likewise, for poorly controlled diabetes, there's an increased risk of gum diseases. So on this note of interprofessional care, I believe that we should also engage our dentist friends, not only in managing oral health, but also advocating for oral health prevention. And all in all, I'm keeping it short, but good oral health can really, enhance quality of life. And it is always too late if the healthy individuals already develop any chronic diseases. So it's always prevention is so-called better. So on this note, back to this web again, I hope that, at the end of today's session, we will not only work together with other healthcare professionals, but also look into how we can continue to work with other healthcare professionals, such as dentists, whom I've shared briefly today. So with this, thank you very much for sitting through, and I wish all of you good health.
Thank you, Dr. Lam. Okay, we will have Q&A session. I will invite you to come here. Okay, next questions from the audience. Please raise your hand. Don't worry if you don't want to use English, not confident enough, you can use Bahasa. Please. So we have students coming from bachelor and then internship, and also we have some students joining via Zoom. Yeah. Okay, please just raise your hand. Don't be shy. Typical of students. Okay, we have here in the middle.
Yes. Thank you, Dr. Lum Zheng Kang, for the insightful presentations. I just want to ask for individuals with non-diabetes and diabetes, especially in Singapore, who are fasting during Ramadan. What are the best food choices for pre-fast meal and post-sunset meal to maintain stable blood sugar levels? Are there specific macronutrient balances or meal timing strategies that can help prevent glucose spikes and crises? Thank you very much.
Thank you so much for your questions. Right. So just to make sure that I got your question accurately, you are asking more with regards to the diet and meal to ensure that they could actually maintain a good glucose control. Am I right? Okay, so I know it's the first question, but unfortunately, I'm actually a clinical pharmacist by training, so I couldn't advise, and I wouldn't dare to advise too much into the nutrition part. But I would encourage you perhaps to read the DAR guidelines. We have a chapter on the Ramadan nutrition plan. We also present some of the research in terms of the nutrition plan and its outcomes. So what you can also do is you can look into these research papers and see how they designed the nutrition plan and the meals to ensure the good glucose control. And in fact, many of these studies were conducted in Indonesia. So the diet and the meals are also aligned to the Indonesian diet. So you may want to look at that chapter. And on top of that, right, we also have a DAR Safar app. You can quickly search in the Play Store. So this DAR Safar app actually has all the information, educational materials for healthcare providers and patients with regards to how they can tailor their nutrition and their meal with regards to the glucose control level. So I hope that these resources may be helpful to address your question.
Okay. The other questions, I think the lady in the middle. Hi.
Oke. Sebelumnya, Prof. Hesti, saya izin pakai bahasa Indonesia ya. Thank you for Mr. Kang for the information that you have give to me. My name is Aura. Saya ingin tanya, jadi kami mahasiswa apoteker angkatan 75, kemarin sempat ada kapita selekta dari industri. Kemudian narasumbernya itu adalah ketua dari suatu industri produksi farmasi. Dia menyatakan bahwa di Malaysia dan di Singapura itu kesehatannya itu tidak dipegang langsung oleh Kementerian Kesehatan, namun dipegang oleh Kementerian Pariwisata. Jadi jatuhnya itu wellness tourism. Berdasarkan data yang tadi Mr. Kang sudah sampaikan, apakah data-data diabetes Singaporean itu ada dari data wellness tourismnya juga atau tidak? Nah, kemudian pendapat dari Mr. Kang bagaimana tentang wellness tourism ini? Thank you.
Okay, they have the lecture previously, and the speaker from the pharmaceutical industry, and the speaker said that in Malaysia and Singapore that the health is managed by Ministry of Tourism instead of Ministry of Health. Is that right? And then what's the second one?
Bagaimana menurut Mr. Kang pendapat tentang wellness tourism ini? Apakah data dari diabetes Singaporean itu ada juga data dari luarnya gitu loh, Bu?
Data luar?
Jadi pertanyaan dia lebih ke data wellness tourism in Singapore gitu Bu.
So what about your opinion about the data from the Singapore wellness tourism? Singapore wellness tourism, is that the database from wellness tourism? Yeah, in Singapore. Yep, that's right. Maybe you have any thought about that? What is your opinion?
All right, thank you so much for your question. So, so with regards to wellness tourism, or if I were to say generally medical tourism, I think that in Singapore, we actually do welcome a lot of our friends from ASEAN in terms of the medical tourism. But I think one concern is really the cost. So right now, our government national initiative is focusing on how we can prevent our residents from developing chronic diseases. But at the same time, we are also strengthening our healthcare infrastructures and ecosystem to support perhaps medical tourism or wellness tourism. But I would say that this would unlikely be a key focus just because it is actually very costly in this aspect in Singapore. Yeah.
Okay, does it answer your question? Yeah. Any other? One from the middle, one from the right hand side.
Before, I like to thank you for Dr. Lum Zheng Kang for the amazing opportunity for me to ask. My question is, for some patient with complication in diabetes, maybe it will be needed more people or more specialists, maybe a cardiologist in the team. My question is, in practice, how many people usually conduct in a team, and is there a best method that used for managing a successful teamwork within the team? Thank you.
All right. Thank you for your question. So, I think yes. In terms of it's important to measure the effectiveness of the team, right? While in theory we say that, for example, diabetes care we require cardiologist, we require dietitian, but eventually when they come together, we always measure like a overall outcomes in diabetes control, such as HbA1c. But in reality, how exactly the care team is effective, I think that is unknown. So this is the point that I'm also driving at when I was talking about the implementation research, engaging the stakeholders. When we asked our patient to see the cardiologist, see the endocrinologist, see the pharmacist, see the nurses, what are their feedback? So actually in Singapore, we are running qualitative study to look into patient acceptance, from there to understand whether do they find value in these healthcare professionals, right? So I hope that this was what you were asking.
Okay, from the right hand side.
Okay, thank you, doctor, for the interesting presentations. My name is Andrea Benita. Earlier, you explained about the diabetic care from the community pharmacies, like the counseling one. Probably can it be implemented in Indonesia, and probably how is the strategy to do it or like improve it? And also from us for the future pharmacies here in Indonesia, how we can join the program or like improve the health of the patients. Thank you.
All right, thank you for your question. So I think you started out by talking specifically about, for example, the Ramadan-specific clinical services. So I would want to address that. In fact, we have this group called DARSI, DAR Southeast Asia. So we are actually running a lot of initiatives in Indonesia as well in guiding healthcare providers in setting up Clinic Ramadan within the setting. But to your subsequent question on the broader scale, how community pharmacists, or just specifically, or rather more pharmacists can come in to work together with the interprofessional care team, and how you can play a more active role. So I think this may be a very difficult questions for me to address, because it really depends on the individual political landscape as well as the policy and system. If you ask me, I think that the very first step is to really look into the overall infrastructures from the policy landscape. How can the pharmacists be integrated within the healthcare system, or is that a push for the interprofessional care team? While I cannot speak for Indonesia, let me talk a little bit about Singapore. So why we are rather successful in engaging our pharmacists, I think there are two main reasons. Number one is that there is a strong top-down push from the government. Like I have described briefly, the Healthier SG framework, where the government is pushing to engage community healthcare providers, and naturally the community pharmacists come in. That is one factor. The other factor is more from the bottom up. We have a strong pharmaceutical society that is also pushing for the roles of community pharmacists to be integrated within the our national initiative. So as recent as this year, our community pharmacists actually lobby and push for involving community pharmacists in providing vaccination services. So again, while I cannot speak for Indonesia, but I think the future pharmacists, for example, perhaps like yourself and your friends, it's important to be united in pushing for advancing the roles of pharmacists. Yeah.
Okay, any other? Okay, while waiting for the question, I'm getting curious, what kind of support provided by the government for this project?
All right, so for these projects alone, which I've shared over the slides, actually there isn't much funding from, there isn't much support from the government, but these research projects were funded by our Ministry of Health. So the funding, in terms of support, would be the funding wise. But I also want to use this point to just say that, again, on the implementation research perspective, a lot of all these very exciting programs ends when the funding ends. So actually what we are trying to do is that we're trying to generate strong evidence. That is why we conducted randomized control trial to actually lobby for reimbursement and sustainable funding from our government. So because in Singapore, our pharmacist services are not reimbursed. So we therefore, because it's also a small community, so we come together, we keep generating evidence, we want to push for the government to recognize that there is the value in community, or rather just simply pharmacists within the healthcare SG landscape.
I think the situation is pretty much the same like in our country, that the community pharmacists are struggling to get any incentive or reimbursement from government. I invite more questions from the audience.
So I think while waiting for a question, I just want to add on this note with regards to funding and reimbursement of pharmaceutical services. So just last week, I was actually in Hong Kong to give a talk, also very similar, to talk about the roles of pharmacists. So in Hong Kong, the pharmacist is also trying to push for greater participation and roles of pharmacists within the primary healthcare system. But one of the struggle is really the funding. So therefore, I think my point here is that it's therefore even more important for the pharmacy community to come together to lobby for this, to show that actually we actually can add value to the entire healthcare ecosystem.
Okay.
May I have?
Yeah, sure.
Okay. Thank you, Dr. Lam, for your presentation. The idea of interprofessional care models, I think it's very important in this emerging era. I think the disease is developing also how we connected to other professional in health system. My questions may be more about in educational system in Singapore. To what extent in Singapore interprofessional care models like you presented integrate in the curriculum or educational system? Is there any kind of program maybe for bachelor degree that collect or a group of 5 different discipline of health professionals, something like that or not? And because I think I experiencing once in my bachelor degree, I'm with other 5 discipline like medical doctor, nutritionist, and nurse and public health. We visit patient with chronic disease, hypertension and diabetes, but it's only a program, not integrate in the curriculum or education system. So my question is, to what extent in Singapore in terms of educational system? Thank you.
All right. Yeah. So I think in terms of Singapore, we in the last few years we have revamped our pharmacy bachelor programs. But in terms of integrating the interprofessional education, it is still work in progress. So actually, over these few years, the blueprint for the university is to work towards having interprofessional education integrated within the healthcare program, so namely the dentistry, the medicine, the nursing course. So right now, at the current state, in terms of education, what we do is that the university designed the bachelor program in terms of the various therapeutic areas. So for example, for year 1, they will learn about the cardiovascular system. So within the cardiovascular system, they will learn the anatomy, the pharmacotherapy, and then we also engage the medical school colleagues to come in to talk about the roles of doctors. We also have the nurses to come in to talk about nursing care and the roles of nurses. Well, so this is the shift towards having our student understand more about the interprofessions, so-called their roles, and this is still again work in progress. But what we have done outside of the university education is within our hospitals, there are more and more interprofessional care team, especially within geriatric care and the aging sector. So we have like an interprofessional care team to manage the geriatric patients in Singapore.
Okay, thank you. Thank you, Ibu.
Okay, we still have a couple of minutes. So, Dr. Lam, you have initiated the project and the results are very promising. So what the next step? So the result can be, the government can uptake the result and can implement in the health system.
Yeah, so because I think we have generated substantial findings to so-called show that there's value in with the community pharmacy. So I think, and also at the same time, as I shared just now, our pharmacy society is actually also lobbying and pushing for the roles of community pharmacists, for example, in vaccination. But I think that there is still quite a bit of work to be done until we really get pharmacists recognized and integrated into the entire healthcare ecosystem. So I think the immediate next step, right, is to really, because we are a very small island and we are quite well connected, so it's not just to run research within a single setting. So what I envision the immediate steps is really to start to engage nationwide kind of work, so that we can also get some of these healthcare professionals who participate in the research to be trained. I think we also need to show that I think one of the concerns is whether pharmacists are capable and competent, to be involved so directly and actively in chronic disease management. So we want to leverage on research to also train up our pharmacists as well.
Okay, your last statement can be the concluding remarks for your talk today. And if there is no other question, we can end this session. And thank you so much for Dr. Lum Zheng Kang for this very inspiring and mind-opening talk. I will hand over to our MC.
Thank you, Prof. Hesti. As we approach the end of today's lecture, I would like to take a moment to express our appreciation to everyone who has contributed to making this event a success. First and foremost, a big thank you for our speaker, Dr. Lum Zheng Kang. Your insight and expertise have been incredibly valuable, and we are grateful for the time and effort you have dedicated to sharing your knowledge with us. Let's give Dr. Chang applause, please. Now we want to present the certificate for you, Dr. Lam. Please come forward. And I may ask Bu Safira, as the representative of the academic leader at the Faculty of Farmasi Pancasila, to present the certificate to our speaker. Thank you, Bu Safira. I would also like to extend our gratitude to our moderator, Prof. Hesti Utami, for guiding the discussion and enhance the quality of the seminar. Please give applause to Prof. Hesti. We want to take photo together, so please come again, Dr. Lam and Prof. Hesti. Thank you. And finally, a big thank you to all of our participants. Your thoughtful questions and engagement have made this visiting lecture enriching, and we appreciate your presence and contribution. Once again, thank you all for being here. We hope you found this seminar beneficial and inspiring. Thank you. Have a good day and goodbye. Wassalamualaikum warahmatullahi wabarakatuh. tes sebelum keluar tunggu dulu mahasiswa, ada presensi offline yang kalian harus isi, presensi online yang kalian harus isi, bisa scan barcode di sebelah sini ya. Silakan scan barcode-nya terlebih dulu, kalau sudah selesai baru boleh keluar.